So we are going to start on time so we can end on time. I'm Andrew Bluestein again, Chairman of Garfunkel Wild. We have most of our panelists. And first of all, I really want to thank you because I know this was hard. You had to do presentations, we had to practice, we had to record. Sometimes we had to record twice. And you came back, so I appreciate it very, very much. Also, as I said at the this morning, which we had our live session there on federal changes, I really want to thank Kim Kempton especially and Greg Bloom, who helped me put this together. It's actually a lot more work than you would think. So what we're going to do is I'm going to ask some questions. Kim's going to ask some questions. And also Stacy Gulick is going to ask some questions. We're going to go in the order of the agenda, and feel free to ask each other questions. The topics were very, very wide ranging. So the first topic that we had after the morning first session was with my newest partner, David Trasky, who was smart enough to leave the government and come work for us. And we're very happy to have him. And also, I wouldn't be doing my job if I didn't do our free commercial, which is Garfunkel Wild yesterday opened our 6th office in DC, and David is co-heading it together with David Morrissey. So David, I, as you know, love talking to you because you've only recently in May left the government, so I still can ask you, what do you think the government would think? When it comes to ASCs, and I know I've worked with many of you on ASC transactions and their governance, people will say, well, we're not exactly in the safe harbor. Remember, safe harbor are these things which if you're in, the government's supposed to leave you alone. Sometimes, like 4 or 5 times an hour, somebody will say, well, we're not exactly in safe harbor because of this or that, but we're substantially in safe harbor, or we're materially in the safe harbor, and put on your government hat. Is it like horseshoes? If you get close, it's good enough?
No, I mean, it's in fact, that's what I was going to say, right? The first thing I always tell people is it's not like horseshoes or cornhole or whatever thing you play where if you get close, you get points on the board. So there is no such thing in the government's eyes as substantial compliance with the safe harbor. So you've got to meet all of the provisions of the safe harbor to be covered under it, to enjoy the full protection that it affords. That being said, if you don't satisfy all of the criteria, understand that it's not an illegal arrangement or setup per se, but that the government's going to look at it then based on the totality of circumstances. And that's always kind of a risky proposition, which may subject you to additional scrutiny.
Okay, but is it helpful? Like if I said to you and I was representing an ASC and I said, well, they were 80% compliant. Is that better than being 30% compliant?
I mean, shades of gray, right? I'll give you the old lawyer's answer. It depends.
Right.
Um,
Geez,
the
you've been in
best
private practice too long already. Go ahead.
the best answer would be, let's help you get set up and lined up so that you're 100% compliant, because ultimately that's where you want to be.
Okay. All right. What about kind of flipping the other side of the question, which is, so I'll have clients say, because every client thinks that they can get on the internet, read the statute, and know it as well as I can, which may or may be true, but they'll say, look, technically I am in safe harbor, right? I am here. So the government has made us a promise that they will never touch us. We get that a lot in, certain GI deals with specimens and things like that. But is that true? If I'm in, I'm in?
It is not. What I would say is, first off, congratulations if you're in the safe harbor and you've jumped through all the hoops to get there. That's great. Um, that being said, it's important for ASCs to remember that there are still other obligations that they have to satisfy. For example, that Medicare only pays for, services that are medically reasonable and necessary, and they expect to see things documented appropriately. So, on one hand, you should be congratulated for being in the safe harbor. On the other hand, don't fall asleep at the wheel and think that that's all that you have to do from a compliance standpoint.
Right. And there's been also some instances, some opinions that I were put out by OIG where they said, we recognize you technically complied, but we're going to look through it. That's scary. But I take it the government doesn't like to, they don't do that willy nilly, right? Because that wouldn't be fair to us who are not in the government.
No, no. I mean, usually if the government is looking at a particular provider, there's a reason that it's doing so. And at least at the OIG, they are not in the business of playing gotcha. They're going to look at things and they're going to go where the facts lead. And if there's nothing there, they're going to look at it, and then close it down and move on. If there's something there, then they're gonna keep probing.
Okay, so one last kind of audible question before I turn it over to Kim to attack Scott and Bob. So like, let's assume Scott and Bob and I guess Andy also, they're doing a deal and they're looking at an ASC and the 33%, one of the 33% tests, you got somebody who's at 28, somebody who's at 25, but they've been doing it for like 8 years. Is it the kind of thing that the government is going to get really concerned about, or they're going to look like at the totality and say, yeah, close enough?
Yeah, listen, if you are satisfying that practice income test rule, then that gives the government the warm fuzzies, because that says to them that you're going to be using, the ASC for the intended purpose and not sort of as a vehicle to get improper remuneration or something like that. But yeah, you're right. I mean, if you're at 29% or 28% or something like that, again, you're going to sort of fall into that bucket of looking at the totality of the circumstances. And one of the things that they're going to look at and want to know about is, why aren't you hitting that mark? And there may be a very good reason for it. So again, it's just one of those things. You'd be prepared to sort of show your math and explain to the government, all of the ins and outs.
Got it. Okay, ins and outs. Kim, attack Scott and Bob.
I didn't know it was this kind of meeting. So thanks both of you for joining back on, and thank you so much for participating in the transaction considerations for physicians. I'm going to start with you. What's the biggest piece of advice you would give to a prospective physician seller looking to sell their practice?
Yeah, it's a great question, and hopefully off the top it doesn't sound too self-serving, but my guidance would be to have really strong outside counsel around you, and that comes in lots of different forms. Obviously, I'm an investment banker. I think investment bankers are important to have in a process. We can talk about why, but I think reputable investment banking support is definitely something wise to have in your corner. But it's not limited to that. I would say obviously transaction counsel, so people like Garfunkel Wild who are really familiar with the types of transactions that you're working on and understand the intricacies of working in the healthcare space, particularly if it's a physician practice deal that brings some additional hurdles, and also the local geography in which the transaction's being done. I know we spent some time in our session talking about the oddities of the New York State environment and trying to get physician deals done in that realm today. People have been through that in the past. They're really worth the added expense for sure. And these are specifically transaction counsel individuals. We've seen them in all form and fashion, and having a non-experienced kind of divorce attorney or something unrelated is not going to serve you well in the transaction itself. Beyond that, I also say on the financial front, quality of earnings counsel and accounting and tax guidance as well. Some of that can come in the form of your attorneys, but particularly on the QV front, it's an added cost on the front end, but should they uncover any additional value through the form of EBITDA, pretty quickly as you apply a multiple to that in a transaction, it's going to more than pay for itself. So I think that's super important to have. And then really kind of on a case by case basis, additional kind of service providers. Again, in a physician deal, depending on the makeup and the track record of that business, clinical reviews in the form of chart reviews can be highly valuable and defensive in nature to ensure no pushback from investors down the road, or IT review if it's a tech-enabled service offering and there's some proprietary technology. Things like that we look to bring into our processes on an opportunistic basis. But I would say having those right folks in your corner who have been through these processes in the past and really can play defense for you while also playing offense, of course, on the value front would be very much advisable.
So Garfunkel Wild commercial, we actually have a subsidiary called GHA, which Jennifer is representing today, and GHA can do those types of coding reviews. And on a seller's behalf, it's actually very helpful because we do it under Covell and it's all kind of together and packaged nicely for buyers. So thank you for bringing that up. Bob, I'm going to switch to you. What are some of the reasons that you see once the doctors get through the whole deal and have all their consultants lined up, hopefully, what are some of the biggest reasons that they might be unhappy or have like seller's remorse?
Yeah, like I said in our presentation, Kim, what I've kind of got a thing to where I like to, when I hear docs that have done deals that say they're not happy, I'm drawn to them because I want to know why. And like I said earlier, the number one reason is that I put it in the category of they missed something. What I hear from them is, if I would have known this, or if I would have known that, I wouldn't have done the deal. And so to me, that makes it that much more important to, going right on top of what Scott said, to really be, I use the saying, always be planning. I've told for years, I've told physicians, it's not when docs say, oh, well, we're not ready yet, we're going to look at maybe doing a deal or consolidating or joining something next year or in 2 years. And that always strikes me as crazy, because unless you're always looking at your options and you're always evaluating where the practice is today, where it wants to go tomorrow, et cetera, how do you know when the right time to do a deal is? So my biggest advice to docs is that always be planning. You always need to be looking. And again, I don't think that I've ever heard a doc say, I wish I wouldn't have done it because they didn't give me enough money. I don't think I've ever heard that reason. But the reason, like I said, the main reason is, I wish I would have, and it can be all kinds of things. I wish I would have known the way the way an exit works. I wish I would have known how the rolled equity and private equity deals really works on the waterfall. I wish, there's so many different things, but it always seems to center on something that if I would have known this, and they don't say if I would have known this, I wouldn't have done the deal, but it's finding out afterwards a surprise. And in doing this and doing any type of business consolidations, surprises aren't good.
Yeah, agreed. On the flip side, what do you think the primary reasons are that a deal doesn't get done, that's gotten traction and then kind of falls through? What are some of those factors?
Yeah, I can jump in on that one. I think there's two major categories I'd put them in. One is under financial performance, and the other one being misalignment of the shareholders. That's particularly important in kind of broad shareholder groups. So starting with the first, I mentioned how important it is to have solid, quality of earnings review and financial review on the front end of a process, not only to make sure that you're uncovering value, but also to find potential pitfalls, right? Like a quality of revenue analysis, like, are we accurately capturing revenue performance and not overbooking that, therefore increasing EBITDA unnecessarily? Should you not have a review like that done on the front end, or not a good one done? And that's found out during the due diligence process months later. you're running the risk of certainly decrease in value of the deal, but also having wasted the prior 6, 8, 10 months just to get to that point, right? So that's one example, but I would say financial performance. Another one that's in that realm could be revenue producers taking their eye off the ball. So physicians that own and operate their practice sometimes get sucked into transaction work, and their revenue hurts because they're not seeing patients as consistently. And so that's another thing. Support through investment banks should be taking off your plate all the transactional work, so there's no suffering on the financial front. And then quickly on the other one, misalignment of the shareholders. It's a broad category, can mean a lot of different things, but it comes down to, do we as a shareholder group really know what we're getting into? Do we know the likely outcome from a financial perspective and what that means to us as a group, but also individually? So a lot of times we'll see broad shareholder groups with vastly different levels of performance in terms of collections by physician. And, there may be equal ownership, but something tells me the higher producers are expecting a higher portion of the proceeds, and where, allowable through tax constructs, that's candidly what we usually see. And so if you haven't thought things like that through on the front end, also governance issues, the type of partner, strategic versus private equity versus hospital partnership, those types of things, you could just end up at the finish line with a lot of misalignment, infighting, and ultimately not getting a deal done. So similarly, wasting a lot of time, energy, and potentially money to get to that point. So I'd say those are the two biggest things, and we spend a lot of time here at Provident trying to head those things off, among others.
Yeah, I have no idea what that's like. I'll just ask Bob real quick, because I know we deal with these things sometimes. What's one strategy you might have to get physicians aligned that are in very different categories, that's like Scott was just describing?
Yeah, so I put it, one word: expectations. And whether it's, as Scott was saying, the quality of earnings, that's the big economic one that, a buyer will come in thinking they're buying, I'm just making this up, $4 million of earnings. And guess what? After the quality of earnings, they find out they're buying $2 million. And so, but again, a seller never wants to say, wait a minute, what do you mean the price that we talked about is going to go down in half? That doesn't go very far. So that's the big one. But again, no matter what, I could give you stories and stories on the idea of expectations. It's very important to manage and to start with the right expectations and continue those, as they change. Things always change as you go through the process.
Okay, all good advice. Thank you so much. Andrew, I will kick it back to you.
All right, thanks. So the next one was the role of artificial intelligence in enhancing healthcare delivery. And Dr. Grasso, I think a lot of people were asking questions for their own personal issues, like, well, what about, treating this, or what about doing that? There was a couple of questions about wanting about mental health services, and that might be the world we're living in now. But let me just pick one. Could you talk about AI? By the way, if you don't know at all what AI is, you might want to listen to this, because I knew nothing, so I could learn up. But Dr. Grasso, what about computer learning in surgery specifically?
Well, computer learning in surgery is undergoing a lot of change as the quality of the cameras have gotten, better and better. So if you think about in the old days, you had a VCR and you had a camcorder and you had a flat screen television, and now maybe you have a 4K television. Maybe if you're a little aficionado in media, you have an 8K television and you look at 8K media, but everybody's aware of those transitions. What people aren't really aware of, and what's challenging, is when you start moving into 4K and 8K video, the file sizes are profound. So 8K surgical video, which gives you an enormous amount of information, requires a lot of compute, which is now costly. And doing a lot of this work in the cloud is prohibited when you're moving exabytes of data around. So the good news is that we're going to be finding a lot of very interesting things in these very large data sets afforded through surgical video at 4 and 8K. But the challenge is that very few organizations, healthcare delivery organizations, have the expertise to begin to even play with those data sets. And that's part of the challenge in AI in general in healthcare, is When you get sophisticated, you need sophisticated people. And whether it's surgical or pathology or dermatology or radiology, you need to have those folks around, and you need the resources around to start playing in that data. So very interesting prospects. And I think you'll be very surprised over the next 3 years of what comes out of all this churn.
And what happens to the doctor who may be very good medically, let's say a surgeon, but just isn't technologically savvy with AI? Could he find or she find that they're really at a disadvantage?
Well, there's the consumer of the resource, and then there's the developer of the resource. You don't have to be an auto mechanic to drive a very advanced car around, but if you want to play with that car or fix it, that's a different story. What I was really intrigued with listening before, and I think it was Scott and maybe Bob, talking about healthcare and finance and selling practices and valuations and all that stuff. I'll just give a little example. I was encouraged by my mentors at Forsman and Little to go get an MBA in finance. So I have an MBA in finance as a physician, which allows me to completely change the conversation when I talk to business and finance folks. Same thing is happening, I think, with technology. If physicians don't tool up with at least foundational education in advanced technologies, not to get an MBA or a master's in information systems, but it's to their benefit to really start to learn some of these core principles as they begin to get exposure to these tools and techniques and platforms. Continuing medical education generally has been clinical. I think it needs to move into the business and clinical realms as well. If you want to be relevant 5 years from now, I think you're, as a physician, going to need to be tooled up in tech and business much more than they are now. So that's a position statement.
Well, let's stay with that. Does that mean Andy and Scott and Robert, could they then say, when they're trying to convince, if they are trying to convince a physician to do a deal, that you might need a lot more capital now because you might need to get some expensive 8K TVs?
No, I think what'll happen is when if forward-thinking folks like you and your firm and your strategic partners, if they go into a healthcare opportunity on a sell or a buy, and they're able to communicate internally, like if you came to me and said, "Hey, Vincent, we'll be doing a due diligence on your practice in 3 months. Get it ready," I would understand what that means, which is best for both sides. If you've got to kind of take everybody from zero up to some minimum feature set, that's not good for anybody. So I think the landscape will change, and whether it's the utilization of AI in a practice that may change its valuation, frankly, the perceived value changes using more advanced technologies if they're implemented correctly, valuations are going to change. And that's exciting, right? That's an exciting next 3 to 5 years of, wow, how does technology affect valuations in a buy-sell environment in healthcare practices? That's going to be fun.
So last question, will AI be able to help with the shortage in physicians?
Yes, AI is going to provide a hybrid human-machine workforce that will, I think, radically change the interaction between, let's just say, the interactions that are not required of a physician, where a patient would benefit from some other third party to get an answer to a question or to impart an instruction. I'm at my office today. I'm seeing patients every 20 minutes. Not all those 20 minutes is my level of trying to bring the most value to my patient. A lot of it is administrative and clerical. And why do you want me to be doing clerical administrative things in those 20 minutes with you as a patient? So I think that hybrid workforce offloads a lot of this kind of unfun burnout labor that we do, and will allow us to be much more value generating with the time that we have, which is a game changer.
So Dr. Koch, I think the only other doctor the only other doctor on the panel, you spoke in your session about anesthesiologists and how I don't quite know how we're going to fix it, but is what Dr. Grasso suggested, could AI maybe help with that?
Probably not. they used to have closed systems for anesthesia that did try to take vital signs on a real-time basis and convert that to changes in infusions of this or that medications. And they found that in terms of the quality of the anesthetic or patient satisfaction or hemodynamic changes, it really was not something that caught on. But like, Dr. Grasso said, if you take a look at your iPhone version 1.0 versus today, it's a completely different world. And my guess is that one day that those algorithms marshaling large data sets will likely be able to make for a safer experience. You'll have to have various accreditation organizations and state licensing and CMS follow suit because, I don't think they're going to pay for a machine, and the system isn't set up for that kind of level of machine clinician interaction.
Dr. Grasso, do we have our first controversy?
No, I agree. As we talked about, Andrew, the AI ecosystem is this three-headed hydra. The machine learning part, where you would have a machine controlling, anesthetic dispensing of a therapeutic agent, et cetera, et cetera. That stuff is all real time, and that requires a lot of tweaking and refinement. But I would put to the good doctor, you'd be very happy to know that if you could increase the ability of getting your pre-anesthesia checklist done correctly and having patients stratified correctly by risk, that would be good for everyone before they even got to the OR. And even those basic things like preoperative checklists, I'm shocked that I still see sometimes those things really aren't done correctly. That you don't need AI to do that, but AI could be a watchdog to make sure that these 12 things were done at least, and when were they done and followed up on. So there's a lot of room, and you don't do the hardest thing first. You do the thing that's easiest, that's the most repetitive. Really interesting time for us.
Yep, I agree with you. I just finished my master's in perioperative medicine and population health, and
Nice.
You're 100% right that by accessing huge data sets, we could use predictive analytics to determine who's at high risk for
Absolutely.
complications and then mitigate it. So to
Sure.
avoid problems. So thank you, Dr. Grasso.
Love
Well,
to
that
talk
was
to you some more,
fascinating.
Andrew. Please
And
raise
now our
that.
time, and that was fascinating. Now our agenda is completely blown from time, but okay. So Jennifer, let's come to you.
Thank you.
President of, that was really fascinating. Thank you. President of GHA. So Scott mentioned medical recording and auditing and stuff like that. So just quickly, I'm a practice, whatever. I've never done an audit. I don't know if I'm doing medical records right. I don't know if I'm about to lose all my money to a payer. Help. What do I do? What's the first thing I do?
So we come in and we assess. So a lot of the auditing depends on what type of practice, how many providers, what types of procedures are being done. So, we come in, we kind of take a look at that. We analyze some billing reports. We always suggest that audits are done prospectively. So that way if changes need to be made, they can be made, the claims go out correctly. But really, generally speaking, if it's a, smaller practice, we can look at 10 encounters per provider. That's kind of industry standard. But where it gets kind of in the gray area is when maybe they're an orthopedic office, there's additional procedures that are being done. So then we would expand that scope of the audit to include some of those more commonly performed procedures. And really what a documentation and coding audit review is looking at the documentation to ensure it's meeting what was being billed out to, to the payers, to Medicare and Medicaid and all of those regulators. So it's important we use AMA guidelines, CPT, and CMS guidelines to ensure that all the documentation supports the codes being billed. And again, can't stress enough doing those prospective audits to ensure claims go out correctly.
So do the audit before you have the gun to your head.
Yes.
Yeah.
On
Okay.
advice.
Got it. All right, Lauren, you had an interesting comment in yours. You said that if you're dealing with, let's say, a nurse or something, and moving patients and lifting is something that's required, put it in the job description, right? And I thought, well, we haven't done that here at our firm, and I don't think we have necessarily, and I bet you a lot of people haven't done it either. So let's say I haven't done that, and it's something that does require manual labor, And now the person comes to me and says, yeah, I can't move a patient, or I can't do this or that. Am I stuck?
Well, that depends. If it's a couple of things. Is the person been working for several years and that's an essential function of their job and they need a temporary accommodation, right? That, it's really fact intensive, but certainly, in your job descriptions, you want to have ADA compliant language that says, you need to lift certain amount of pounds, or you need to be able to move things. And if you don't have those, it's really then going to come down to whether it's an essential function of their job and whether it's a reasonable accommodation to remove that function. So taking the example, for instance, that you just gave, whether or not you need to, move patients, there may be a temporary accommodation that can be provided that would be reasonable, but there may be times where it's not reasonable to take that away from someone's job function. So that's why you really want to have it in the job description. But either way, it's going to be important. It's going to come down to whether or not something's reasonable in terms of when an employee asks for an accommodation.
Okay, so I should have said this. Lauren, among other things, is also an HR expert at our firm and gave the lecture Navigating Human Resources in a Healthcare Setting. So Lauren, you could yell at me later, but I got a phone call from a practice 15 minutes before we started. Tomorrow, there's some day of rage or whatnot that is talked about. And they said that an employee said, I don't feel comfortable coming to work. Right? I said, I'll call you back, which meant I'm going to call Lauren first and discuss it with her. So there's no right or wrong answer. And I know, Sal, you do this too, but what's your initial gut on that one?
I mean, look, this is sort of unprecedented, right? When someone asks usually for a religious accommodation, it's because they need a day of observance, or there's some other reason why they need an accommodation. Maybe they need an extra break for prayer time. I mean, this is sort of unprecedented. So yes, I will yell at you later for putting me on the spot on this. I mean, but you also, in addition to religious accommodations, you also just generally want your employees to feel safe, and you want to provide a safe workspace. So, I know a lot of people are really fearful, and we're all seeing these reports. So it's really also a question of whether, you feel there's, you have concern for your employees' safety, and if you can accommodate that, that's certainly something that, I would recommend just from a sort of a human standpoint. But whether or not it's a reasonable accommodation is really sort of unprecedented and not the type of thing you usually see with respect to a request for reasonable accommodation for religious reasons. But I certainly, just from a, thinking out loud, if you can accommodate someone with that, I see no reason not to, but I don't think it falls into what we generally see for reasonable accommodation.
And you also might run into a problem of granting it for one and not for another, right?
And that's why I said, if you can accommodate, great, but that would be something that you consider. When you consider a reasonable accommodation, you consider what might be an undue hardship and whether or not you need to grant that accommodation. I would look at that same analysis here, and certainly if it's one employee and it's a business that can accommodate, or it's two employees as opposed to your whole workforce, that certainly goes into the equation.
Okay, so thank you. We'll be talking later. Okay, so Doria, I'm going to ask you, for those who might not have heard your presentation, can you quickly tell me what exactly a total quality management program is and why I need one, and what might be difficult if I was to say, okay, let's do it?
Sure, Andrew, we'll do. Total quality management program, it's so, if you think about an overarching, a branded umbrella, envision that, and some brands that you might see on there are names such as CMS, accrediting organizations, Joint Commission, AAAHC, Quad ASF, and even the state gets their hands in it. So it's a framework of standards and directives that we want to just qualify all these great things we do in our organizations every day. CMS probably has the largest voice, and those accrediting agencies will tweak it and put their spin on it, and so will the state. One of the biggest challenges for leaders trying to implement that is really understanding what are all those very moving parts, or those spokes under the umbrella. So if I would share any best advice to a organization trying to implement a quality program, I would say take a step back and just know who your external resources are. Where can you go to get the information? Go to the CMS website, and the accrediting organizations, if you're sort of accredited by Joint Commission or AAA, they spell it out for you. It's easily spelled out. From your identifying your external resources, and your internal resources are yourself and your staff. If you envision one person holding an umbrella, you don't want to see one person holding an equality umbrella. It's really a team approach and a team effort. So that would be first approach, understand what road you want to go down, have a clear vision of the quality pathway you're going down, and enlist your team, your experts on your team to help you kind of roll that out.
Okay, because one of the questions I got from someone, because you are, if I get this right, the Director of Clinical Support for PEGI Solutions, and they wanted to know if you would help them with things other than GI. And I guess what you're saying is there are resources that you don't need a consultant for. Am I hearing that right?
So, quality, yes, there are resources out there. CMS has a website. The accrediting organizations, they spell it out in their standards. There are folks out there who consult for quality programs. Absolutely.
Okay, great. All right. So
I think one of the things people could do is call Rami Johnson, if I'm not wrong, because I did listen to your program, and I think you are representative of one of those outside organizations, right?
Absolutely.
Yeah.
Okay. Well, okay. Thank you. And Rami, you are not practice specific or specialty specific?
No. I'm from an accrediting organization, and we're accredited throughout all the specialties, single specialty, multi-specialty. We really focus on ambulatory surgery centers and office-based practices as well.
Okay. So let me keep picking on you because Kim threw you under the bus, so we'll stay with you. If I get it right, you come in, you do what you do, and you're with the accreditation of Commission for Healthcare. So ACHC, you come in. How long after you leave should we expect a survey?
So the way, maybe you mean a decision, because typically what will happen is we'll have a surgery center come to us and say, hey, we want to have a survey and for the purpose of becoming deemed by CMS.
Right.
And that survey itself is going to be unannounced. So I think to your question, the latter part, after the survey occurs, which is usually about 2 days, typically you'll hear from the accrediting organization, whether it's ACHC or whoever you choose. With that, you have to hear back from them within 10 days, because that's when the plan of correction, you'll get the form listing all the findings. So you have to hear from them within 10 days. And then after that, it really depends on the accreditor. Most accreditors really expedite the process. So to your question, I think a lot of people really, one of the questions I hear is, hey, how quickly can I get the decision, the letter, so I can get the CCN?
That's what I meant.
If there are no major findings, and what I would categorize as major is any physical environment findings, that you have to do construction. If none of that is found during the survey, typically I'd say no more than 30 days. You can hear back, because 10 days to get the plan of correction, then the ASC has 10 days to respond back, and then sort of the back and forth moves on from there. So the process moves pretty quickly.
And let's say you come in and you find really bad things. Obviously, you'll tell, let's call it an ASC, but is that confidential, or can the public find that out?
So if the public requests from CMS, they can. So usually what happens is after the findings have been complete and the plan of correction is set in place, the accrediting organization does send that information to CMS. So for us, we don't publish the survey report on the website, and neither do the other accrediting organizations. However, CMS does have that report. So I guess technically, if there was a scenario where that's needed, the public could request that information from CMS directly.
And maybe this is too cheeky, but how much does it cost to get one? to get
Yeah,
you? Yeah.
Yeah, no, that's a good question. So it's going to depend on several factors. All of the accrediting organizations, they usually bill based on how many surveyors they're sending on site and how many days that they're sending. So typically you'll see ranges from between, let's say, 14,000 to about 19,000, depending on, how, again, those two factors. The other piece that most folks forget is it also depends on whether you're multi-specialty practice or single specialty. The reason for that is the more specialties you have, the more records the surveyors have to review, which means more time. So to your question, I'd say between 14,000 and 19,000 per cycle, which is about 3 years.
And I know you can only speak to your organization on this one, but do you sometimes show up unannounced even after you've been accredited?
So after you become accredited, typically the first survey is unannounced, so the initial one, and then after that, you're good for 3 years unless there is something like a patient complaint. So let's say if we receive a complaint, then we might have to show up to validate that. So those are the only cases where, as an accreditor, we might show up unannounced. Now, that being said, CMS have every right to show up unannounced anytime. They recently just came out with this new process where they're actually going to be tagging along their accreditors to do the validation surveys. So that will be interesting to see how it develops. But CMS, obviously, at the end of the day, they can show up whenever they want to, even after we have already come on site and validated the quality of care you provide.
I see. Excellent. Okay. All right. Andy, you had the most interesting, for those of you who didn't make it, affiliation option for private practice. The most really varied, I just want to say. You had PSA, you had private equity, you had doctors who had done a lot of different things. And I thought that was exciting. What do you see as the most activity? Like at this point, with so many deals already happening, if you had a race, where are you seeing the leader, and where do you see somebody coming up from the back?
Yeah, it's a great question. As an investment banker, one of the things I work hard to do is really help educate groups on the full spectrum of options. I think there's a perception that bankers are here just to push deals to private equity, and that private equity really is the only option. There's a lot of other ways to grow and scale, and one of the things I worked hard to build a dynamic of a session. I think it was a great discussion, was really having leaders that represented all different options. So we had a physician that entered into a PSA agreement with a large health system down in Atlanta and has been really successful. It's a large orthopedic group in Atlanta that has basically doubled the size of his practice, through that arrangement, and transitioned a lot of the resources off his balance sheet and kind of simplified the operations dramatically, while still getting the benefits of a scale partner and investment partner. We don't hear a lot of groups talking PSA as much, but I do think, in certain markets where you've got a strong health system that's got deep relationships in the community, large referral opportunities, that can make a lot of sense. Then to kind of offset that, we heard with Jeff up in Illinois that just brought together two large mega groups to form this large mega practice from Ortho Illinois and Ortho, it was Rush Ortho and Illinois Ortho coming together. And it's pretty exciting when you kind of bring two groups together. Obviously brings a lot of challenges and complexity. So just kind of exploring the governance and the complexities there, but was great to hear that. Of course, we had some private equity perspectives as well, like Andrew Carlson, who partnered with Growth Ortho, and then Dr. Cavana, who also partnered as well. And so, I think really the takeaway from our session is that there's no one right model. I think groups should really consider and evaluate all models. My advice to groups is always you got to really start internally to understand what your true objectives are and what you're trying to solve. I think it's all too often that groups kind of dive headfirst into these exciting discussions about big cash numbers and mergers, and before they've even done their own internal assessment of where their gaps are, what the actual capabilities are that they're lacking, and what is it from a partner that they're looking to accomplish. Because I'm a firm believer that none of these deals are going to be successful 5-10 years from now if there isn't strategic value that's being created beyond just the near-term economic lift. The economics are going to be long forgotten. And so, that's where you got to think long into the future, particularly around what's going to set you up for, value-based care initiatives, right? And as more and more of these markets move into more risk-based arrangements, global payment models, how are you going to set yourself up in those arrangements? And so, I don't think there's one main model, right? We didn't talk about hospital employment as much. I don't know that I see that as much, a favor. And I think, standard private practice is probably less, candidly, if I would say status quo is probably not a great option, just given the threats and complexities of all these new entrants moving into healthcare. I do think groups are going to need more capital and they're going to need more resources. And so they got to find a way to get bigger.
Yeah, I thought your session and the way you just summarized was great too. You reminded us that there's a lot of different options, and sometimes I think lately we were all losing sight of that. I would also tell you that on the hospital, it's been my experience that hospitals are starting to pay higher multiples than they ever were before this. And I think part of that is there's just, if you want to grow, there's not a lot of growth opportunities. So you can end up having, if you say I'm only going to buy tables and chairs, well, then that's going to limit you. So thank you very much. So before we end with smoking pot and talking to Sal, I want to ask Stacy, because I feel like I need to get whatever surgeries I have to get really soon, because I might not be able to get anesthesia soon. So Stacy, why don't you take it away with Dr. Koch?
So Dr. Koch did a great job of explaining to us the extent of the shortage of anesthesiologists and the reality that it's just simply not getting better. And he explained to us that really, if we want to address this crisis, we can't just throw more money at anesthesiologists. This is just not going to work. I mean, maybe in the short term a little bit, but not really. So we have to look at creating efficiencies within our facilities or looking at alternate providers. And one thing I thought I always understood, and I'm not sure I'm right, but is there actually reimbursement available for these alternate providers to provide the anesthesia services?
Yes, there is. And the circumstances surrounding it vary from, as you might imagine, payer to payer, and from type of provider to type of provider. But as we've examined and looked at alternative providers, we've done so out of necessity, not out of desire. And we were surprised to learn that the options are pretty clear. And my advice always to colleagues is really talk with counsel and who understands medical and billing, because you try going it alone, it's perilous. But if you work with the right counsel who knows what they're doing, then they'll steer you straight.
And so if throwing money is somehow not going to be cost effective to attract anesthesiologists, is there anything else other than money to bring them into our surgery centers? Is there anything that helps that can bring in traditional anesthesia providers?
I wish there was, but you're looking at draconian shortages at least until 2030, 2032. It's going to get really bad and people have to buckle up. And unfortunately, if you take a look at improving utilization on a per room basis to try to contract your footprint, which means you need less people, well, there goes work style out the window because you're going to be working harder and longer. So unfortunately, the quagmire that we find ourselves in is going to not get better anytime soon. And none of the data I'm looking at looks anything but discouraging.
So what I'm hearing is that we're going to have some seed change. We're going to have perhaps longer hours in a single operating room or less operating rooms running at the same time and different types of folks than what our surgeons are typically used to. And that's hard. Change is hard. We all know that. So do you think the surgeons understand this issue? Do you think other doctors than anesthesiologists really appreciate what they're facing?
It's not clear to me at the hospital executive level, ASC owner level, or individual clinician level if people understand the underlying drivers to supply and demand kinetics that are predicting what's going to happen. And like Dr. Grasso said before, is, having that fluency is important. And if you don't have it, all you're dealing with is, wow, it's short. What am I going to do? And they do end up throwing money at it. Soon that won't be enough. The average anesthesiologist is making 2 or 3 times what a pediatric oncologist is. The average CRNA is making double what a pediatric oncologist is. Wow. That is not a sustainable solution. That is not good for healthcare. And we have to do something about it. And it's going to require innovation and collaboration with wise people that understand regulations, reimbursement, and accreditation standards, which the people on this phone call are far brighter than I am about that, particularly Andrew.
Oh, I mean, after hearing that, I need to start smoking. So let's start this now. Sal, let me ask you a question. Actually, I'm sure Mark has a reason for this. It happens a lot with anesthesiologists where they seem impaired. It happens with every specialty, but over the years, I think anesthesiologists have led that problem. But so somebody shows up in Mark's office or at a surgery center that Mark's at, whatever, okay, and they seem impaired, okay?
Right.
Whether it's from pot or whatever it is, marijuana, I guess I'm dating myself, or whatever it is, who's to make that call? Is it always the same person? Like who decides if somebody's impaired?
I think the gold standard in some states like New Jersey are trying to articulate this, that gold standard would be you have one person who's trained and understands signs and symptoms to look for in an objective manner to make that decision so that it's consistent. Well, that might be what New Jersey wants and strives for. I understand the practical realities might not allow that at your surgery center. So I think it's someone, high enough up in an HR chain, if you have it, with the input of the individual's supervisor or director to help make that decision and guide it. And what I mean by that is you'd want a baseline. Mark would want to know how his physicians are presenting on a day-to-day basis and why that physician seems off today, unlike one of those other days. So I think that correlation of, the supervisor along with someone you designate who has some training, background, understanding makes for a good person to make that decision that the employee is objectively impaired and we need to take action.
Okay, so Mark's the person, sorry, Mark, I'm picking on you, but Mark is the person who's knows me and was certified by the practice to look into this. And he says to me, I want you to go take a blood test. And I say, hell no. Can you fire me on the spot?
No, not in and of itself, because the blood test isn't really going to show much in terms of talking about cannabis. Maybe it might show if you're under the influence of alcohol at the moment, but when you start getting into blood tests and breathalyzer tests, courts frown upon them, and the human rights organizations also look down upon them. So you're really looking for more other signs outside of that pathological test, where you're going to look for glassy eyes, slurred speech, inability to follow direction and guidance, and what might have led up to an incident. So no, it could be grounds. I've had some situations where someone refused because it was a requirement of the job in a particular job setting. But outside of those rare occurrences, refusing alone, it might not be the best grounds to terminate someone.
Okay, so what about if Dr. Khan says to me, you seem a little glassy-eyed? And I said, yeah, no, I am, because I have migraines. And I have a little card here, which I'll show you, that I'm allowed to smoke, okay, or whatever, okay? But I'm fine, I can do my job. what would you advise Dr. Koch?
So in that situation, if it's putting patient care at risk, that's a situation where I say, we can now move forward with the termination. You don't necessarily have to, in terms of if you think the person can be rehabilitated or counseled, or they made a mistake or misunderstood what their doctor had told them with respect to use of legal medical cannabis. But if someone's telling you, I'm impaired on the job right now, or I'm under the influence, maybe not, they don't think they're impaired, but they're under the influence, that's going to rise to a level enough of grounds for a termination, or at a bare minimum, some type of discipline. But it's, that's a more rare occurrence, but I've had a few of those where those have actually come up and someone's admitted they're under the influence.
Okay, so last question. Will every panelist be able to get like a special lollipop from you, which has cannabis? Is that part of what we're dealing with?
Yeah, absolutely. And the attendees too, we have a separate batch for them as well. It helps. That's part of our new, marketing promo. So I'll be working on that.
Okay, and I just want to make one program note and then thank everyone. There was supposed to be another panelist, Dr. Avishai Newman, but he actually is volunteering at Soroka Hospital in Israel. So we hope he's safe and applaud that type of volunteerism. Thank you very much, everybody. This was fascinating. We covered, as usual, a lot of really good topics. This will be on the internet, and we oftentimes get questions and we will send them to you. But this really is a great educational experience for everyone. So thank you and have a great day. Appreciate it.
Thanks,
Thank you,
Andrew.
everyone.
Take care,
Thanks,
everyone.
everyone.